Welcome everyone here in the auditorium in Jette at the Vrije Universiteit Brussel. Welcome everyone at home as well. This is a special day for Amarins, Kevin and Andrea, because today we celebrate their PhD. They already obtained their PhD, but that was during one of the multiple lockdowns that we all enjoyed over the last 2 years. And because of the lockdowns, they didn't have a chance to actually defend their PhD in front of an audience, because they were sitting in front of their laptop while receiving and obtaining their PhD. And that was a bit unfortunate, especially because of the always enjoyable celebrations afterwards. And therefore, today we will give them the opportunity not only to present a bit of what they have learned over the last couple of years, but also to enjoy the celebration afterwards, which is the part that will start at 7 o'clock this evening. And that's why several people are still in their car right now. They don't mind that they miss this first part, because they are driving into Brussels through the high traffic, because they want to enjoy celebrations afterwards. So it's my true pleasure to introduce the first PhD of today who will present, and that's Amarins. And what I've learned from Paul van Wilgen, my fellow promoter of Amarins PhD, is that that I can fully support what he always says, is that you are such a kind person, that you are somebody who gives a lot of joy and enthusiasm to people living and working together with you. In fact, you own a state in the United States, because Florida is called the Sunshine State, and you are obviously sunshine for the people living and working together with you. And you have done very nice PhD work. Your research was actually also very much in line with your personality, in terms that, of course, it addressed patient-centered care and approaching patients in a very personal way, and it also had a real focus on collaboration among different clinicians. That's why it was a transdisciplinary approach, your work, and Unraveling Pain Together is therefore a perfect title for your work, but also somehow reflecting of your wonderful personality. So, Amarins, the floor is yours.
Good afternoon, everybody. First, I'm gonna see how I can. Here it is. We have to wait a minute for some computer issues. Okay, perfect. The start of today reminded me of some of my international conferences. Where somehow the start of my presentation is always rushed, because, for instance, I forgot to upload my presentation. But here we are, and in the preparation of today, one question came to my mind. When reflecting on my PhD, I thought, well, we have patients and physios, but in the end, it's a bit difficult to really ask ourselves who of those is in pain. And in order to answer that question and maybe reflect on some future studies as well, where I would first like to do a few steps. Oh, the computer is working. Why can't I? So I know a lot of you listening today know quite a substantial amount on pain and on chronic pain, even more than I do, but for those who are less aware, I would like to start with a few minutes on pain and chronic pain because it introduces why it's such a pain in the ass. Then talk about who is in pain and why are they in pain, how can we help them with some reflection on my studies and on the future. And then a conclusion for now, because we know research is ever-changing and the conclusions of today are not going to be the conclusions of tomorrow. So first, we know that in chronic pain, there's differences in the central mechanisms that allow pain instead of patients with acute pain. If I burn my hand, my nervous system signals and allows myself to stop touching the stove and to heal and to be careful with my hand in order to heal the tissues. And as the tissue damage lessens, we know that the pain also diminishes. However, in patients with chronic pain, often we know that there's an upregulated nervous system, so the peripheral sensors as well as the spinal cord and different areas of the brain are more active. And this is not just a nervous problem, but it's also an endocrine and immunological problem. That being said, it's not changing. How is that possible? So like these computer technical issues, patients often have technical issues within their central nervous system that makes their body, their nervous system, upregulate signals that are not potentially harmful as pain. And whenever we experience pain, whether it's acute pain like touching a stove, but also in chronic pain, we know that there's different factors that influence our pain. So if I had a lot of sleepless nights due to my little boy, I know that the bruise on my knee is going to hurt more than when I felt vital, I was less anxious, I was less tired. And even in acute pain that happens. But also in patients with chronic pain, we know that factors such as cognition, sleep, their lifestyle habits, stress, influence the pain we experience. One of those factors is pain catastrophizing. So the rumification, the magnification, and helplessness we feel on our pain influences different brain areas and is linked, in a decrease in pain catastrophizing is also linked to a decrease in our central mechanisms. And we thought, prior to my PhD, well, maybe if that happens, then also the link between illness perceptions and symptoms of central sensitization might also be moderated, so the different slopes and the different levels of pain catastrophizing might moderate the relationship between illness perception and pain catastrophizing. And what we found that this does not moderate that relationship. And that might be due to our amount of people in the in our sample size, but it also might be because the people in our sample size did not have really high levels of pain catastrophizing. But if we look at it more broadly and more with a helicopter view, pain is always multimodal and always individual. And I believe that in the future, multi-method studies, in which multi-model studies, in which the different factors and our difference between the day are a future. Because if, for instance, I recuperate in my sleep or feel less depressed or stop smoking, that's going to influence the pain I experience. And that's a big part of my PhD. I truly believe that in order to put a step forward in healthcare, but also in research, the individual components of patients are really important. And we studied that with qualitative research, because qualitative research allows for us to research the views patients have and to enter their world and their and really study the different shades of gray that quantitative research does not always capture. One of the things we studied was transdisciplinary pain education, because we know that as pain is complex and the factors that are influencing pain are also complex, healthcare professionals often struggle with monodisciplinary care of patients with chronic pain. And transdisciplinary care where the healthcare professionals, so the physiotherapist, the psychologist, the doctor, truly work together with shared knowledge, shared boundaries, shared responsibilities in mutual learning and growing environment, has the possibilities to overcome the problems we face with the treatment of patients with chronic pain. And in that treatment, pain neuroscience education or pain education is really important. We know from study research that pain education in the treatment has its place in the treatment of patients with chronic pain, but not just simply that. Again, pain is complex and individual, and just educating patients on pain is not enough. So what we studied was, first, how can we influence the relationship between the healthcare professionals and the patients by patient-centeredness. And what we found is that even though patient-centeredness is about the patient, placing the patient in the center of the treatment, it's more about the physio. It's more about the characteristics of the physio, the confidence of the physio, the knowledge and the skills of the physio. And as a reflection on that, I believe that undergraduate students as well as postgraduate students, physios that are already working in our field, should be trained more and more into patient-centeredness, but also into really adopting and having a biopsychosocial attitude. Because often we are biomedically trained, and leaving that biomedical view behind is difficult. And within the treatment of those healthcare professionals combined, so the transdisciplinary healthcare treatment, we found that patients who received those treatments found it really important that the healthcare professionals invest in that first part, in that patient-centeredness, that they invest in that therapeutic alliance. And again, those characteristics of those healthcare professionals came back from the views of the patients. Then they found the education understandable, and they mentioned that it's an important step, an important prerequisite to understand why other treatment modalities, for instance, such as cognitive behavioral therapy or relaxation, or giving life a little bit slack and not trying to do your best effort, but taking a few steps back is so important. And it's also made them realize why those treatments do not mean that the healthcare professionals feel that it's something in their head, but it's that education really linked the bridge between the biomedical views as well as the biopsychosocial world. And then we thought, well, we now know what those patients feel, what they think, what their views are. Yet, what does happen in that treatment? What does happen during that education? And how do healthcare professionals, for instance, deal with resistance and ruptures and repairs in the therapeutic alliance? And how can we theorize that in order to explain or maybe train other healthcare professionals with the same ideas? So we did an observational study with video cameras. And again, what we found is the importance of the therapeutic alliance and how they did that. But also that it's not just something that the healthcare professional does, but also something that the patient does. And the education in itself sets a spark into cycli of having doubts about your problems and having doubts about the education, but the way the healthcare professionals and the communication skills that they use, and it's too much to explain in a few minutes because qualitative research is always really broad and with enormous amounts of text. But the way they did that sparks a cyclus and in the end helps patients understand which factors influence their pain and how the future treatment can help them with it. So if we helicopter about that as well, of course my research has had flaws, as any research has had, and especially in qualitative research, generalization of your results is difficult into other for instance, monodisciplinary care, because it's transdisciplinary care and it's in the Netherlands, and that's also always a bit cautious. So it's about the reader really reflecting on what they read. But in the end, I would like for the education, undergraduate education, postgraduate education, to really invest in the biopsychosocial views, to invest in the factors that make us tick, and to invest in training physiotherapists into the therapeutic alliance and patient-centered care. Because if we do that and if we get trained in that, then it helps the patient in front of us. So that's what I did in short. Are there any questions? So then I would like to call Jo back to the stage.
No, stay in it. Yeah, first a big applause. I think that's what we Not only for her PhD, but also for giving this talk so fluently without having access to her slide, which is quite a challenge, I would say.
Yeah, I think I forgot a few of them.
Also, but I have one question, Amarins, for you, and not so much about the content of your PhD or anything related to that, but rather the process that you went through, because of course you were in a special situation in the fact that your PhD was self-funded, and that you did it, that you combined it with your clinical work, both in your own clinical practice and also in the transdisciplinary center, Transcare, where you also did your research. Then, of course, you were far away from university, and that's also a challenge, of course, as compared to many other PhD candidates who work full-time at the university while they do their PhD. What would you advise to people who also consider undertaking such a clinical PhD combined with their own clinical work and doing it from long distance from the university? What would you advise them based on your own experience?
Well, first of all, it took me quite a while. In the end, it was supposed to take 3 or 4 years, but it took me 7 years. And I really believe that I was fortunate to have Jo here in Brussels with his knowledge, but also have Paul in Groningen, in the northern part of the Netherlands, as my promoter, and combined with both your knowledge as well as him being present to help me with any questions I had, that really helped me. Combining clinical work with a PhD is hard, I think, but any PhD is going to be hard and hard work. I think the advantage of my clinical unfunded PhD was that I had all the time in the world. I had some deadlines in my mind, which I crossed again and again, but I had all the time I wanted to do, and I had any chance to do the research I really wanted with the points I wanted. There were no shortcuts in the qualitative research I did. And throughout my PhD, I really learned to trying to find English words, but I learned to realize who has the knowledge and who you need and where you need to be. For instance, Leonard Vogt has really helped me with the qualitative aspects of my observational studies, and that's also an advantage of pain and motion, because we have so many different researchers with so many different fields of expertise that you can really grab them by the jacket once you need it. Yeah, and it's also made my clinical work better, I believe. Yeah.
Wonderful. Thanks a lot, Amarins. Please.
Yeah, that's when you look at the studies, it's different. Some patients prefer more passive roles, whereas others prefer more active roles. But all patients feel that it's important to feel supported by their physiotherapist, as well as their physiotherapist having their back and feeling of empowerment. Yeah, but the active choice, whether it's more paternalistic style or a more coaching style, depends on the preferences of the patients. Yeah.
Thanks a lot, Amarins. I think you deserve another big applause. We'll have a 1-minute break to fix the technical issues, and then we will continue with Kevin's lecture.
Er staan te veel presentaties open. Ja. De presentatie stond 2 of 3 keer open. Ze presenteerden vanaf de verkeerde presentatie. Deze staat ook open, die moet ook niet openstaan. Zo. Ja, oké, dat is het. Deze tip we niet nog mee openen. Als deze gewoon fullscreen is, dan werkt het gewoon, denk ik. Toetsenbord. Deze. Of was er nog meer?
Nee, die mag ik moeilijk dicht doen. Ik ga dan dat het zo weinig mogelijk is.
Oké. Aha, misschien dat die net open stond. Ik weet niet of dat hierop staat.
Zonder de dicht?
Keuken, hier, die was net. Welke was het? Het is best om de presentaties gewoon één voor één te openen. In ieder geval als deze op fullscreen blijft staan straks. En de andere, er staat een andere presentatie open, dan blijft die andere fullscreen staan. Maar nu werkt hij gewoon. Kijken of deze ook.
Okay, technical issues are fixed. So we can continue with the next wonderful personality, because I think that's what all three colleagues have in common. They all have a different, unique, but very kind and great personality. And that applies especially also to Kevin. I think Kevin is one of the kindest person I've ever met, and he, with his PhD work, but also in his other jobs that he does during daily life, he connects different areas, and that's also why I think he did his PhD, because he connects science with clinical practice. He integrates as one of the pioneers worldwide within sports physiotherapy the biopsychosocial model of pain, and that also is highly reflected in the PhD work that he did, and also in the work that he is doing right now. Also, he became now an entrepreneur, if I can call him that way, because he also created with colleagues Next Academy, which also connects science and new findings into clinical practice for teaching clinicians. So Kevin, it's up to you now. I can continue with giving you compliments, but I think that's not why people are here today, so they want to hear you.
Thank you, Jo. I don't know if I'm tall enough to get over the screen. Okay, thank you for the kind introduction, and thank you for giving us the opportunity to do this PhD symposium. So as Jo briefly mentioned, I had the opportunity to do a PhD in which we combined some things in the biopsychosocial elements. In my studies, it's about shoulder pain, and we focused a little bit on the athletes, so on the performers. But in preparation of today, we decided not to talk too much about the PhD itself. So that's why I will do my presentation today on medieval food habits in Western European countries. Of course, that's a bit of a joke. We will do some things about shoulder pain, chronic shoulder pain in athletes. But what I wanted to add today is how did my patient reflect on the PhD? So does my shoulder pain patient benefit my PhD journey? And let's start with a brief general introduction, because I think it's important to state that in the general population, shoulder pain is quite prevalent. It's the third most prevalent musculoskeletal condition. and with huge lifetime prevalences, huge incidence rates, and what probably is even more of a problem is that after 1 year, 40% of all these shoulder pain patients still experience significant shoulder pain. And well, that's also an enormous economical cost that comes from this chronic shoulder pain. So if you see all these people, difficult in COVID times like this, but it happens here and there. Well, imagine that these are all people in Belgium with shoulder pain. Then this cohort is 40%. So that's a lot of people that will end up in chronicity. So, and as I mentioned before, I wanted to bring some cases today. So how did my patients reflect on my PhD? So I have to talk a bit about patients. And this is case A. She is a 37-year-old female with chronic shoulder pain. She experiences the shoulder pain for about 4 years, maybe even slightly longer, after a car accident with fracture luxation of the humerus. So we will come back to this lady in the next few slides, but try to remember this is case A. And she belongs to the 40%. So she definitely is a chronic shoulder pain patient. You also mentioned that I have had the opportunity to work a bit more specifically, not only with the shoulder pain patients in general, but also in the performance cohort. And we know not only, maybe not at all from studies, the epidemiological studies of chronicity and shoulder pain in athletes is really sparse, but we know that there is quite a lot of chronic shoulder pain, for example, in the overhead athletes. There is a high recurrence and it is quite impactful on their career. And that brings me to case B. So this case is at this moment 29-year-old male Olympic swimmer. So I think he was twice in the Olympic finals, and he had a Bankart repair. So it's a stabilization procedure in the shoulder when he was 18, and ever since he experienced recurrent shoulder pain. So he is also a case that I want to bring in this presentation. So I think that states that chronicity, both in the general population of shoulder pain and in the specific population of performers, is a problem. And therefore the main goal in my PhD was to study the chronic shoulder pain within a pain science perspective in general, but more specifically also in a population of performers. And we did this by trying to combine some knowledge and experience and research in shoulder pain, trying to combine it with the pain science and with the performance science. So the region where my PhD was located is, when you see the letters here, it's in A, B, and C. That's exactly where my PhD studies are. You can find them somewhere over there. And the main findings in my PhD were that there are no differences with respect to pain measurements when we compare chronic shoulder pain patients with healthy controls. We'll come back to that later. These are just the main findings. We also found that those who are a bit more physically active, or those who train more in the athletic population, they show a lower mechanical pain sensitivity, and they are also burdened with less negative psychosocial characteristics. And I think we can complain and we can conclude, and Amarins also highlighted the individual aspect for each of our patients. Well, it's the same in this population of shoulder pain and athletic shoulder pain patients. So it's complex, it's multimodal, and it requires an individually tailored biopsychosocial approach. So when we go a little bit in depth within the shoulder pain patients in general, have to talk a little bit beyond tendons and joints. And when we talk about central sensitization, I think most of you are familiar with the term. It's a pathophysiological mechanism that can explain the ongoing pain, that can explain probably the transition from acute to chronic pain situations, and it can amplify pain experiences. But what's important is that we cannot or we should not equate chronicity or chronic pain with central sensitization. So not every chronic shoulder pain patient can be categorized as a patient with the characteristic of sensitization. And therefore, we need to do assessments, I think, both in research and in clinic. And in our research, we have had the opportunity to do, for example, quantitative sensory testing, condition pain modulation, temporal summation in our chronic shoulder pain patients, and also a bit more specific in the athletic population. So for those who are maybe not that familiar with some of these terms, for example, when we try to say something about hyperalgesia, let's go a little bit back. In the quantitative sensory testing, we want to, for example, find signs of hyperalgesia, widespread hyperalgesia in our chronic pain patients, also in the chronic shoulder pain patients. And we can use pressure pain thresholds, pressure algometry, both in research and in clinic. So let's say, for example, person A is prone to a progressive pressure stimulus, so a bit more and more pressure every second, and at a certain moment he or she says, oh, this is a bit painful, this is uncomfortable, and that's the PPT, that's the pain pressure threshold. And in a patient with hyperalgesia, this pressure pain threshold is a bit lower, so the same pain intensity comes with a lesser amount of pressure. We also looked for conditioned pain modulation, so that's maybe more applicable in research, but I think in the pain centers, in the university centers, for example, they use it in clinical practice also, but in my private practice we don't. So conditioned pain modulation is actually doing, for example, the same pressure pain threshold and repeating the pressure pain threshold while there is another unpleasant sensory experience. And then we see in healthy populations that the pain intensity with the same pressure drops a little bit. And so that's something we can use in our clinical research. So that's what we did in our shoulder pain patients, and we try to find some answers in our shoulder pain patients on both these research questions. The first research question is, do patients with chronic shoulder pain differ from healthy controls with respect to what we call psychophysical tests, so the QST, the pressure pain thresholds, the CPM, etc. And we also try to find associations, possible associations with the physical activity status or sports participation. And this is a study we have published in 2017, where we did a quite broad quantitative sensory testing protocol. And actually, can go on to the next slide, because on everything we tested, pressure pain threshold, conditioned pain modulation, temporal summation, we did not find any differences on group level between both groups, both the healthy controls and the chronic shoulder pain patients. And when we go a little bit in the numbers, you see here the mean values, for example, of the pressure pain thresholds on the left-hand side, but you see that there is quite a huge amount of variability within the cohort. And if we reflected, for example, the pressure pain thresholds in the clinical group, so in the shoulder pain group, and we did the pressure pain thresholds on the painful shoulder. Every spot you see here represents one patient. So you see here that there is a huge amount of variation in the pressure pain thresholds. And the red line is the mean value. But for example, you see here 3 individuals that show quite low pressure pain thresholds. And when we go back to our cases, case A and case B, I'm quite positive that case A is known with extremely low pressure pain thresholds at the shoulder region, and case B, I'm probably not able to push hard enough to give him the painful amount of pressure on his shoulder. So he's really high in his pressure pain thresholds. Now, in our cohort in the study, what was apparent is that the 3 individuals that we have defined here with the low amount of pressure pain thresholds on the ipsilateral shoulders, on the painful shoulder, they also showed low values of pressure pain thresholds away from the shoulder, even at the calf, at the middle finger, and at the contralateral shoulder. I have to be honest to you, with our case A, I never tested the pressure pain thresholds remotely. So I don't know if she has lower pressure pain thresholds. I can imagine, I don't know. But she does not experience widespread pain. So that's, from a clinical point of view, I think quite important. Because we know the clinical algorithm. Let's go a little bit. In my opinion, there are, in this matter, 3 types of shoulder pain patients. It's the shoulder pain patients that are actually widespread pain patients with shoulder pain. Then you have the shoulder pain patients with widespread pain, and you have the shoulder pain patients without widespread pain. Maybe it's a bit flu, but in our case A, well, we can be confident there is an absence of neuropathic pain, but the pain she experiences is disproportionate. And as I told, she's not a widespread pain patient, but well, in my opinion, it's a disproportionate pain patient without widespread pain. Case B is nothing about disproportionateness, so he is not in the clinical algorithm towards central sensitization. So let's go a little bit further on case A. So she is a shoulder pain patient without widespread pain, but the pain is disproportionate, and she sometimes comes with a central sensitization inventory above 40. Even this year, I have measured CSI twice, and at one moment it was, I think, 48, not sure, and at another moment when she was a bit out of a stressful period, out of her exams, because she's doing an extra education, she drops to 14 or something. So for her, I think the central sensitization is an issue, but probably not always. It's not always the driving mechanism, the primary driving mechanism of her pain, but probably that's an item for discussion. Now, what's let's say some secondary findings in this study is that those patients, that's exactly in the patient group that we saw this, those patients who are more active, they show higher pressure pain thresholds. So they are less hyperalgesic, and those who are more catastrophic, they show lower pressure pain thresholds. And again, I can be quite confident that case A is a catastrophic person. She shows lower pressure pain thresholds. And case B, well, he is quite active. He trains more than 20 hours a week, and he has high pressure pain thresholds. So let's go over to research question 2 and do these patients with chronic shoulder pain differ from healthy controls with respect to psychosocial characteristics. These results are not published yet, but we try to find some results related to both the fear avoidance model and the common sense model. So we used the pain vigilance and awareness questionnaire, the pain catastrophizing scale, the revised illness perception questionnaire, and the profile of mood states. And we were actually the first, at least we didn't publish it yet, but in the cohort of non-specific shoulder pain, this use of IPQ, illness perception questionnaire, is not at all prevalent. I think we are still the first to have used it, but it's not published yet. What we did found specifically with the illness perceptions is that those patients that show with shoulder pain, they identify quite a lot of signs and symptoms and causes to their shoulder pain, and it's quite diverse. And they also show a high variability of illness beliefs. So this again explains why the individual approach is so important, because you have to tailor the different illness beliefs. The shoulder pain patients, when we compare them to other widespread pain patients in the literature, they tend to have better expectations. So they have better expectations for the future, perceive their problem to be less recurrent, less chronic, and they expect less negative consequences. And these expectations, we know in the shoulder pain patients are quite important for their positive prognosis. So the individual approach is important in case A, in case B, but also in case C, D, E, and even so on. So that's really important, an important message, I think. With respect to the other questionnaires, well, we did found in the shoulder pain patients versus the healthy controls that they show more signs of depression. It was measured with the profile of mood states, and they show higher amounts of catastrophizing and helplessness. And probably there is again a role for sports participation as a mediating or a moderating factor. And as you see in the figure on the right-hand side, you see that within the patient group, those who do not sport, and that's sport less than 2 hours a week, they show less signs of helplessness more signs of helplessness when compared to those who are more active. So in conclusions for the shoulder pain patients, central sensitization is not a characteristic feature, but it can be present in individuals probably. The shoulder pain patients, they show signs of depression, catastrophizing, and especially the helplessness. We don't know if it's the cause or the consequence, so we only found the association. They show diverse illness perceptions, probably a moderating role for sports participation in this cohort. And I think in research, probably subgroup analysis would be quite helpful. In clinic, it is the individually tailored biopsychosocial approach. I briefly want to go to the shoulder pain and performance part of my PhD, and that's right in the middle of this graph, in which we try to find an answer to, does exercise-induced pain modulatory capacity differ in performance with and without shoulder pain? So actually we wanted to know if performers, and in this case it were musicians that performed more than 30 hours of musical activity each week, when they did an exercise, a physical load, whether or not there was a shift in their pain threshold. So whether or not there is an apparent and now my English exercise-induced hypoalgesia is there. Okay. So briefly, it was there in every patient, in every control. They showed adequate exercise-induced hypoalgesia. They also showed a good stress-induced hypoalgesia. That's something different. So this gives us the idea that the brain orchestrated hypoalgesic mechanisms, they work perfectly fine, and probably we can use it in our clinical reasoning about the possibility to exercise in or with pain, both in case A and case B. I'm not that afraid to do exercises with certain amounts of pain. In case A, when she is in a state of dominant central sensitization, probably I will be a bit more gentle, but in both cases, whenever possible, in the shoulder pain cohort, I want to go to exercise even if it's a bit painful. So we have already discussed the conclusions because I started with the conclusions. Not going to do that anymore. I just wanted to end with case A and case B because I actually asked both of them what they experienced related to my PhD, whether or not they benefit my PhD. And these are some of the responses I have received from both of them. So they are quite positive that their clinician is involved in research, motivated to engage in physical activity is an accomplishment with my case A. She stated that this trajectory is for her a reassuring thing. And in case B, in the Olympic swimmer, let's look. What I'm a bit proud of is the latter thing. He said that I had a clear methodology in the necessity of medical imaging. Well, actually, I'm always the first to state, hold on with the medical images. Let's try to do the proper clinical reasoning beforehand. So I think he's also happy with me as a research clinician or a clinical researcher. I don't know. Further, I hope as you mentioned before, I try to have some impact on my patients individually in clinic. We have launched Schoudernetwerk Vlaanderen a few years ago together with lots of fine colleagues. I have had the opportunity to talk at conferences about this matter, both in the shoulder area, but also in the athletic area. For example, next week I have the opportunity to talk about the biopsychosocial aspects of pain for all coaches in the National Swimming Federation, so not clinicians, but just try to educate them a little bit. And I hope that's a bit helpful, and probably that's related to my PhD trajectory. So thank you very much, everybody, and looking forward to the presentation of Andreas and afterwards to have a drink with all of you.
Wonderful how you connect your own cases, your own patients to your own scientific findings. Very nice.
Thank you.
Questions from the audience?
Yeah, probably it is. I I remember probably even before my PhD started, I was involved in the Flemish Swimming Federation, and they had their, how do you call it, their fitness room, their occupational room, in which, well, obviously they could not swim in the fitness room, but they do the tri-land training in there, and there was a physio table within the fitness room, and I really think that's a bad idea. So I think that's about 10 years ago. I came there and I said in Dutch, this is not a swimming federation, dit is geen zwemfederatie, maar dit is een revalidatiefederatie. And up till today, those words still follow me, because exactly they have probably too direct of an access towards the medic. They have a visit from a sports physician every week, and I can imagine, for example, in professional football, there is a medic in-house. I know some of the clubs, they have medical imaging apparatus in-house, and I don't think that's always a good, I don't think that's always the best opportunity. Some cases, obviously, yes, but for example, in our swimmer who just experiences some shoulder pain in the beginning of a harder training period, that's just normal, and they have to deal with it, they have to cope with it. So, don't know if that's an answer to your question.
Other questions from the audience? If not, I can perhaps ask a final question also about the process, because of course, Kevin, you combine so many roles also now, but also during your PhD trajectory. Your role as a loving, caring father, your role as a clinician, as a teacher, as a researcher, as a also entrepreneur right now. So how did you manage to do it all together, and do you have any tips or tricks in terms of time management for PhD candidates who are having similar issues?
It was not always easy. Probably you have to ask this question to my wife, but she's not here today. I don't know if she's following. I don't think so, but it's important to have great support, and both from colleagues in my practice, in my clinic, who is asking the difficult questions today. Also from the team of supervisors, because I don't think it's always that easy to cooperate with someone who has a lot of things to do. For myself, of course, there were some negative periods, but after, so my PhD was, I think, about in a period of 8 years, but never full time. I can only reflect on it as a good period in which I was able to merge some of my professional roles together, and I hope it helps all of these professional facets to a better quality.
Wonderful. Thanks a lot, Kevin, and give him another big applause.
Thank you.
The final speaker of today is Andrea Polli, Dr. Andrea Polli, that is. I think the Pain Emotion Group is known for the biopsychosocial view on pain and chronic pain in particular, but that doesn't mean that we shouldn't emphasize and also focus on the biology of pain. And I think among all the pain emotion researchers, I think Andrea is the one who knows the most about the biology of chronic pain, and in particular on epigenetics. Epigenetics is a particular field of rather new science in general, but also especially in the field of chronic pain. And Andrea is one of the people who got into that field of science, especially in the field of chronic pain. And the nice thing about it appears to be pure biology of pain, but epigenetics is also a very nice way of connecting the biopsychosocial features of pain all together and looking at it from a real epigenetic viewpoint. So that's really nice and that's really unique, and therefore it's my true pleasure to invite Andrea to this podium. Also, it's a very nice example of how international the Pain Emotion Group is. We first had Amarins from the Netherlands, then we had Kevin from the beautiful country Limburg, and now we have Andrea from Italy, so that's also really a nice way of exposing the Pain in Motion as an international team. Andrea, the floor is yours.
Okay. Good afternoon, everybody, and thanks for coming here today or to follow it online, and thanks to Jo and Pain in Motion to organizing this symposium. As you know, this is just an excuse to have a drink all together afterwards, something that we couldn't do earlier during the actual PhD defense last year because of the pandemic. So as you understood already, the aim of this presentation is not to present the results of my PhD. This is something that I did during the public defense already, but rather the idea that we had with Kevin and Amarins was to reflect a bit in a broader way on what doing a PhD means. So during a PhD, you are supposed to learn how to conduct methodologically sound research. And I think most PhD students reach the goal, but I think that this is not the most challenging part of doing a PhD. I think the most challenging part is to have, at the end of it, a broad and deep overview of your own topic, to be the expert of your own topic. And that means to have broad and deep overview, but also to be able to think multi-level, okay? And so what I'm trying to do today is to link, given also the presentation of Amarins and Kevin that were more clinical in a way, to link the research that we've been doing in the last 5 years into a bit the clinical part, to see whether this fits with the patients in front of us. So my PhD was about, as you mentioned already, biological mechanisms associated with chronic pain. And the topic in itself is very interesting. To dig into biology was fascinating. There's a lot of things we still don't know, and I think if you're curious enough, the feeling is you never stop learning. But I'm first of all a physiotherapist, and before starting my PhD, I worked for some years actually as a physiotherapist, so I cannot not think whether what I'm doing is relevant to the patient. If I can transfer the knowledge that I'm getting during the PhD and working in research to the clinical practice, which is also ultimately why we do research, or why we are supposed to do research, or at least this is what we write in grant applications. So if you're a medical doctor, even though translational medicine and translational research has different problems, because it's where most basic research stops and fails to reach clinical research, the patient in front of us, you still have several problems on how to do properly translational research, but at least it might sound pretty straightforward, right? You have basic research, you have some knowledge, you try to apply the knowledge to the patient, you try to identify a number of molecules that you can target with your drugs or your treatment, and then you hope your patient will get better because of your treatment. But if you are a physio, it might be a bit different. If you think how can biology and knowledge about biological mechanisms can help the physiotherapist, it might be, it's a different story. We don't target specific mechanisms ourselves. We don't target a very specific, the expression of a cytokine or a molecule in plasma, right? And so when I asked myself, and this is actually a question that I was asked many times by colleagues as well, can I better help the patient if I know more of the stuff? The answer that I gave myself is no. So thanks for having me, goodbye. No, I'm joking. So the answer is, I think, is still yes, not perhaps in the traditional way. So not in the way we have a protein that we study in basic research, we translate it into the patient and we target it with our mechanisms. But I still do believe that a broad understanding of biology can improve clinical practice of physios as well. So to explain this, here's a bit my take. So let's start saying that we normally rely on models to understand pain, right? To not only to understand pain, but to interpret reality in general. And I'm not against the use of models. I mean, some of them can be useful, some of them can be rather wrong, or they can in the end turn out to be wrong. Think about the biomedical model. We used to base our, at least medicine used to base practice into the biomedical model, and now we know there are several limitations which we should take into account. But in general, models are useful, right? Especially if you have, for instance, limited expertise, you are at the start of your clinical research, you need a guide. Because that's what models do, in my opinion. It's a guide. They guide you into the complexity of the clinical encounter. But the risk is, my point is that the risk is they can also limit your clinical reasoning if you base your clinical practice too much into models. Models are like lens, okay, through which you see and interpret the world, see and interpret the reality, the patient in front of you, but they also point towards something. They make you focus your attention towards something. So let's take the fear avoidance model, for instance. If you think that fear is really important into the clinical presentation of your patient, you will seek for fear-related symptoms, fear-related behaviors, and if you happen to not find any, you might start thinking that you did something wrong yourself, right? You're limited to the model that you have in mind. You try to fit the patient in front of you into the model rather than fit the model to help understanding the patient in front of you. And this can go even deeper, I think. We don't necessarily need a model to shape our thinking. The way we learn things and the way we teach things can be enough. In the last few years, we realized how important the nervous system is in understanding pain. But if we focus our learning or teaching only to one system, even though it's not a model itself, we are still contributing to provide perhaps a limited framework of understanding for these patients. On the other hand, a deep understanding of biological mechanisms makes you acknowledge complexity, makes you stay open-minded and acknowledge the complexity of the human being. And the more we understand how different systems work, and the more we take a neuro, endocrine, immunology view, the more we add the mechanisms that can possibly explain the clinical presentation. Okay? So as I said, if we rely on models, we might tend to constrain reality into the models. If we had a broad understanding of biological mechanisms, it will be easier for us to listen to the patient and then try to think what might be explaining, what might be contributing to the story and the narrative the patient is telling me. And this is important because it's validating. You don't start from the model and you try to fit the patient into the model. You start from the patient. You understand, you know that what they are saying is right, and your work is just to say, okay, I might have the mechanisms, I might have the explanation why you feel this way. Okay, this is validating for the patient. And validation is the first and important step of the therapeutic alliance. So I think this is really important. If you keep a broad mind, a broad overview, it's easier for you to then follow the patient rather than try to put the patient in a box. Of course, the drawback of having such a broad overview is that it never finishes. Knowledge will accumulate, and it can happen that the more you know, the more you have possible explanation for the patient. So at some point, knowledge in one person are finite. And one second point that I think in this case genetics and epigenetics are important is that genetic and epigenetic mechanisms make you acknowledge vulnerability. Some people are just vulnerable, more vulnerable than others to develop chronic pain. And that's through no fault of their own. This is a powerful message for the patient as well. We don't fully understand it yet, but for instance, we know that most chronic pain conditions show some degree of genetic heritability, predisposition. And that's generally between 30 and 50%. And one important thing here is that predisposition and vulnerability is not solely genetic. Epigenetic mechanisms can also contribute to vulnerability. And just to briefly introduce epigenetic mechanisms, they are those mechanisms that do not happen in the DNA, they're not mutations. They happen around the DNA, but they can still influence gene expression. They can still influence how a certain gene or group of genes work, okay? And epigenetic mechanisms might be of particular relevance for us physiotherapists because they actually respond to the environment and to lifestyle factors. And I'm going to give you a couple of examples to let you know what I mean. So if you think that the environment and lifestyle can influence our own biology, that's pretty cool, right? And this is in fact what scientists think nowadays, that epigenetics is a rather cool area of expertise because it might have huge potentials for future development of treatments. And I usually use these examples from animal. Before I started my PhD, I had no idea that whether a bee becomes a worker bee or a queen has nothing to do with the genetic material, as the DNA is exactly the same. What changes is the diet they get. So if a bee with the same genetic code gets a worker jelly, they will develop slower and they will go on becoming a worker bee. If they get the royal jelly, they will become the queen. Okay, and that's something that kind of shocked me when I first learned it. And this can be observed in humans as well. For instance, if you look at identical twins when they're born, it's difficult to understand who's who, right? But as they grow up, as environment and lifestyle kick in, you start to see differences, you start to recognize them. And if you don't know this film, it means you're very young, so good on you. So other example that I think are very interesting and kind of summarize a bit of everything of what I've been talking about so far. So the importance of environment, the importance of lifestyle, as well as the concept of vulnerability linked to epigenetic changes. So one example comes from studies on cortisol. So we know that, let's say, cortisol is sometimes referred to as the stress hormone, right? So the one hormone that is closely linked to stress. So now we have initial evidence from animals and humans that if you have an early life stress, like for instance a trauma or frequent hospital procedures, or in the case of mice, low maternal care, for instance they take the mother out of the offspring as soon as mice are born. So these kind of stressful events in early life, they change through epigenetic mechanisms the way that the stress genes work, okay? And this is already, I think, interesting, but the most interesting part comes later. So you modify the stress system, and that the changes that you make with the initial trauma or early life stress is still present in adulthood. So your stress system, even when you're an adult, will respond differently because of the early life stress that you had. So basically your stress system is changed. We know that the stress system is linked in multiple ways to pain, but also, for instance, to immune system. So it is not difficult to think that epigenetic change is happening very early in life because of the stress procedure or event can contribute somehow to vulnerability to pain. That has nothing to do with genetics. It wasn't something already there at birth, right? And the second example comes from the literature on opioids. So you know that opioids are part of our just descending modulatory system, and it's also one possible option and possible treatment, especially for acute pain states, for instance, after surgery. Okay, when they studied OPRM1, so the gene that you see listed in the slide, which is the gene that encodes for the receptor of morphine and strong opioids, they found two interesting things. First, that long-term opioid users, can be heroin or it can be opioid users because of medical procedure. So when people use strong opioids for more than a year, they have higher DNA methylation, which is an epigenetic mechanism. You don't need to know what that means now. But that means that those epigenetic mechanisms will then have an influence on how many receptors that person has. Okay, you have more methylation and you have less gene expression, so you have less receptors for the opioids. So you have less substrate that is needed for the opioid to work. And this is interesting because we know that opioids decrease their effects in the long run, right? The more you take opioids and the more people tend to get addicted to it, and they need a higher dose to have the same effects. And now we know that it might be actually the long-term effect, the long-term use of opioids that has the effect. So it's a vicious circle. And the second interesting finding is that, so let's say that, so yeah, it's the second point. So higher DNA methylation of the OPRM1 gene can predict poor outcome after spinal surgery. So what they did is they enrolled children basically undergoing surgery for scoliosis, and they found that those who had higher methylation before surgery didn't really respond to the treatment with opioids. So the interpretation is again that they have higher methylation, so they have less receptors, and that's why they are not responding to opioid treatments. And this group of studies, especially the second ones on opioids, can also point towards precision medicine, I think. If we could identify in advance patients not responding to opioids or who need a lot of opioids to have an effect, we might actually change our approach, right? And so we don't risk them to get addicted to opioids and so on and so forth. And we have other examples, for instance, on how epigenetics, biology in general, but epigenetics specifically in this case, can be of help in the clinical world. Exercise is one treatment that we physios use a lot, hopefully, and we know that exercise, just one bout of exercise is enough to induce changes in over 350 different genes. So it changes the expression in over 350 different genes in muscles. And there are several different interpretations that we can give to this finding. For instance, just for you to know, it can be relevant for cancer as well. When somebody has cancer and is recovering from cancer, there are some drugs called epigenetic drugs that are now used more and more. They are in phase 2 or 3 clinical trials, so they're about to be marketed. And these drugs target a specific group of enzymes that are called histone deacetylases. And why I say this? Because we know that exercise, regular aerobic exercise, has the same effect of those drugs on those enzymes. Okay, so epigenetic might give our treatments, right, the reason why they might work. Okay. So looking at those findings, we try to summarize and outline that the combination of different genetic and epigenetic mechanisms and the environmental factors contribute to how our body systems work. Okay, and that might predispose somebody to a certain disease. And in this case, it's pain, but it can be diabetes, it can be cancer, it can be inflammatory diseases as well. The good news here is that if part of that predisposition and vulnerability is not solely genetics, but is also epigenetics, it means that we might work. We might work on it and try to reverse at least part of it. And then this is from my PhD, just to mention that we actually did some work during my PhD. It's not only this big introduction about epigenetics. We did the systematic review, and we actually, evidence is limited, but it seems to confirm existing data into the literature saying that patients with chronic widespread pain have altered pathways in the nervous system and the immune system. So this is something that we know already, but it's important to confirm. Okay, it's chronic pain is probably not related to something wrong in muscles, in bones, in peripheral structure. Is rather linked to the nervous and the immune system. And we actually did try to measure some of those proteins related to the nervous system and the immune system ourselves, trying not to fall into the death valley that I mentioned in the very beginning of the presentation. And we have a number of results that we think are interesting or worth further exploration. That's what we're doing. I'm not going into it because that's something that you probably, most of you, if not all of you, already listened to during the public defense, so I'm not repeating myself. So just to end this presentation, I think why a physio should have a broad understanding of biology to treat patients with chronic pain. First of all is because understanding biology makes easier to understand the clinical presentation. You stay open-minded and you actually listen to the patient's narrative and try to say, yes, it makes sense to me. I have a broad understanding of how body systems work, to actually back your experience up with biological mechanisms, and that validating for the patient for sure. It makes you acknowledge vulnerability. It makes you acknowledge that somebody is just more vulnerable to that condition. Okay, it's not their fault. It can be some genetic or epigenetic predisposition. We can work on it, but it's important to know that somebody is more vulnerable. It's important because they might predict treatment responses, and so we can act accordingly depending on the epigenetic profile they might have. And also because it might represent the substrate explaining why our treatments or our approaches work. For instance, exercise, diet, stress management, sleep management, and so on. But this is just to cover a bit more the clinical perspective on the topic. Of course, I had other reflection on the research perspective, for instance, how not to fall into the valley of death of translational research. And for instance, how important it is to have a proper designed study, especially with repeated measures, because variability of the biological measures is an issue. But this is for another time. So for now, I thank you for your attention.
Amazing, Andrea. Getting back to your bees, what kind of food we will get afterwards? Will it be the royal jelly or the workers' jelly?
It's royal jelly for everybody. We're all queens.
Good to know. Questions from the audience?
I'm looking at you now. No, I'm joking.
Questions from the audience?
Thank you for a fantastic presentation. The early lifetime stress, can it be, the impact of it, can it be reversed during lifetime?
That's a very interesting question and relevant question as well. It can be reversed, but of course what happens early in life is way quicker than what happens in adulthood. So the idea, we don't know it yet, but the idea is that changes happening early in life are very quick, because we actually have they call it sensitive periods in epigenetics. So during embryo development or during early childhood, epigenetic changes happen very quickly, and then they most of them somehow stabilize over time. They're more stable over time. So if you want to change something that has been built into one of those sensitive periods where everything changes so quickly, you really have to do a constant job for a longer period of time, for sure. It's exactly the same as learning. No, yeah, okay, thanks for the interesting question. So, yes, so you have a trauma, okay, that can happen in a moment or a few days, for instance, when they take the offsprings out of the mother, it can take a few days, and then when you assess them, rats are more sensitive to pain, for instance, they show hyperalgesia, they show signs of anxiety and stress right away. But the thing is, that sort of anxiety and stress is maintained in adulthood, right? So basically every time they face a new stressful situation, the stress system is like going crazy, okay? So it's more difficult for them to approach the stressful situation in a healthy way. Okay?
There's one more burning question in the room for you. Can you please invite the audience to the party afterwards?
Yeah. So it's a pleasure for me that now we just, as soon as we go out, we probably walk all together to the Chalet du Laarbeck, which is like 300 meters from here. And as I said in the beginning, we are going to have a drink all together. Okay, thanks.